so, as you can see, the phase 1 is the intraoral simulation mock-up, wax-up mock-up. Phase 2 is evaluation of this mock-up comfort, function, phonetics, aesthetics, of course. And finally, phase 3 is the reproduction. It is an improved copy of the mock-up in the form of the porcelain restoration. So it's a systematic approach in all these cases. And it allows us to do things like you see on the screen. This patient came with very short teeth, and now you see a normal width by length ratio that was restored. This was the baseline in this case, a very short worn down teeth. And the patient was in this specific situation requesting more incisal guidance. It's rare, but it happens. So she was delighted to have these longer teeth with more incisal guidance. And if you follow this guideline, I have personally not seen a patient complaining about this excessive guidance. I'm still waiting for that to happen. And so don't believe that to minimize stresses during tooth-guided protrusive movement, you need to reduce the length of aesthetically correct teeth. This is not right. This was made in this patient, and you see how short the teeth ended up, all the same length. This is a disaster in terms of aesthetics, and it was also a disaster in terms of function. So by re-establishing the patient's the central incisor prominence and length, we could re-establish not only function but the patient's smile. And there should be no fear to do that. Remember that ideal occlusion is not only a functional thing. It is not only physiologic, it is an aesthetic, also an aesthetic outcome, and this goes together. So there must be a consensus on the aesthetic and the function together. And you see the difference for this patient, left versus right. There was no operation on the gingiva in this case. Just by making teeth more prominent, as you can see, the gingival smile was reduced just because teeth are now the main element in the smile and not the gingiva anymore. And more details on this smile. So we were starting to talk about type 3 extensive restorations in the adult, and what I mean by that is extensive coronal fractures, extensive loss of enamel by erosion and wear. And of course I say in the adult because most of these indications in children are better covered by the use of freehand composite restorations. When the patient gets older, to the age of reason, now we could debate what is the age of reason, but let's say they start to be a little quieter and the risk of trauma is decreased, then we can think about restoring these teeth using porcelain. And I want to show you one of the most exciting indications in my opinion is the treatment of extensive coronal fractures like this case. This is a severe loss, as you can imagine. The patient had a fracture when she was a child, and there was maybe a pulp exposure on tooth number 9, I imagine. That was well treated. She had composites for years, and now she's consulting, and like many of these patients, after they had composites for a long time, she's consulting for a more stable and aesthetic type of restoration. And she thought I was going to prep 2 crowns on her teeth. And I looked at these teeth, I removed the composite, and what I found was insufficient to place a crown. And actually, if I wanted to do a crown on this central incisor, I would have to find stabilization and retention, and as you can imagine, through endodontic therapy, post and core build-up, maybe crown lengthening, etc. Lots of procedures, unnecessary, because by using adhesive dentistry we can maintain, as always, a maximum amount of tooth substance, which we did through the very traditional preparation of a veneer type restoration. We just prepped the remaining part of the tooth like we would do for our traditional veneers. We rounded off all the transition line angles at the incisal edge, as you can imagine. We used a mini chamfer all around the buccal interdental area. You see that on the left, the incisor was prepped on the incisal, very flat, very simple, while on the right incisor we used a deep chamfer into the cingulum area, which was the area of fracture. And this makes absolute sense. You never want to do a chamfer into the concave area of the tooth. You want to use a butt margin. While when the fracture is so deep in the cingulum, then you can use a long chamfer to increase your bonding to enamel. I want you to know these cases I did when dentin bonding was not efficient and I was not really using any bonding agent to dentin. That was bonded mainly to enamel by enamel etching, as you can guess. Michel used back then the refractory dye technique with almost 3 different bakes. As you guess, a bake for opaque dentin buildup. Significant opaque dentin must be used in these cases if you want to have a nice transition between the freestanding part of the porcelain and the part of the porcelain that is supported by the tooth. Then a main dentin bake, and the remaining space was filled with enamels and opalescent masses and so forth, as you can see here. Now here is the final result. What is how would you like to call that? Is it a porcelain veneer? Not really. Is it a crown? Not really. There is no stabilization and retention. This is really what I like to call a bonded porcelain restoration, and it's going to be attached to the tooth mainly through bonding. We will not have any stabilization and retention. Bonding in this case to enamel, as I told you. And you can see the final result maybe a week after placement. There is significant guidance. Did we make the incisor shorter in order to avoid too much guidance? No, absolutely not. We made them the length we thought was reasonable for aesthetics and for function. And you see there is only guidance is mainly on these 2 teeth, and this is not a reason to shorten them. We will have guidance on the restoration, and that's not a problem. 5 years later, you see the situation is almost unchanged. There is no alteration, no decay, no infiltration. Now, of course, the only change is really the migration of the gingiva. Now the margin becomes slightly supragingival, but is still invisible because we are using light cure resins to bond this restoration, regular light cure composite restorative types material. You see the very nice, beautiful result with guidance, of course. And I want you to look at these pictures. What is the difference between the left and the right here? The difference is only time. It's time. It's exactly 10 years of function and service. 10 years, and you see the minor alterations, the minor changes that occurred. Mainly the main changes at the gingival level, because this patient was 18 when we placed these, and now she's 28, and therefore there is a migration of the gingiva. That is occurring without any pathology. It's a normal post-eruptive movement of the gingiva, and you guess the enamel at the cervical aspect, but the result is unchanged, and the porcelain is doing well. There is still the same guidance. There is no major antagonistic wear on these teeth, and you see that the enamel, opposing enamel, was not mistreated by the porcelain. Newer generations of feldspathic porcelain have lower grain size and much less abrasivity to the antagonistic enamel. This is why this is possible. And you see the patient now, you see the palatal margin. There is a visible margin. Why? Because enamel is stained all over, but the porcelain does not stain as quickly and as easily as enamel, and this is the reason why you see this difference. But there is no decay, there is no infiltration, there is no fracture, there is nothing wrong with these teeth after 10 years, and you have seen the amount of porcelain that was placed on this incisal edge. This is actually the very first case we did together with my brother. It is the same situation, an extensive fracture. The patient had composites that were removed, and the teeth were prepped like regular veneers on the remaining part. Unfortunately, as you see, the patient had an herpes, a gingival herpes, when I decided to start the case. So this is not my iatrogenic lesions on the gingiva, but just a herpes. Michel used the same feldspathic type technique we still use today, refractory dye, feldspathic on refractory dyes, and you see the amount again of porcelain that it was used on top of this incisal edge. So this is the final result. Remember, as I said, every single of these cases has been tested and simulated first in the form of a wax-up and a mock-up, where the patient could test this final outcome under a certain time, and that's very important. There would be a lot to say about the before-after views in this case, but look, the rejuvenation of this smile, and as I mentioned before, it was placed by unique enamel bonding, etch bond to enamel, and the porcelain was etched silanated. I will comment on that a little later. And there was significant guidance again here, as you can see on these pictures. A couple years later, 7 years later, as a matter of fact, you see the intact enamel on the lateral incisor compared to the porcelain on the central incisor. And you see how the gloss and the beautiful work of the porcelain was maintained. So you see the final X-ray, and again you see the amount of porcelain that was placed over this incisal edge. How much is that? 1, 2, 3, 4, 5, at least 5 millimeters of porcelain simply bonded to the remaining tooth substance in the form of a partial veneer. 10 years of function. You see the situation is still very stable, no major changes. Patient was extremely happy, and this is the very first case, so it's now 12 years old. And you see after 12 years a slight staining at the margin on the distal part of the number 8, but this is very easy to solve with a little bit of polishing with silicone points. Otherwise, there's nothing we can say. You see that the palatal margin was not ultra accurate. There's a large amount of luting composite that is exposed, but because the luting composite is a regular light curing restorative material, I will explain why later, this margin doesn't stain, doesn't give any ditching, serious infiltration or serious problem, and can be maintained very well.